This is the practical on osteology and surface marking of the thorax. You will have to study this lecture and also the handout which will be uploaded to Moodle. Once the university starts, we will let you have the bones and you can go through this again. But the surface marking you can do at home using the handout and this lecture to aid you. You can do the surface marking on one of your relatives at home. Now if you talk about the thorax, you must have seen when you looked at a skeleton previously when you were studying upper limb that the whole of the thorax is actually contained within a bony cage, and that cage we call the thoracic cage. Now if you look at a picture of the thoracic cage, you see that it is made up of several different bones. So what are these bones? There are 12 pairs of ribs, right? One rib on either side. So 12 pairs of ribs. Then in the midline you see what is called the sternum. And then behind posteriorly you see 12 thoracic vertebrae. Now all of these form a cage like thing which is open on the top, which we call the thoracic inlet, and at the bottom where it opens into the abdominal cavity, this aperture here is covered by the diaphragm in the living. Okay, so during this lecture we will learn about the different component parts of the thoracic cage. Okay, so this is actually the posterior aspect of the thoracic cage. Here you can clearly see the 12 thoracic vertebrae which form the posterior boundary of the thoracic cage, and you can see that the ribs are coming and articulating with the thoracic vertebrae. Okay, so let us learn about the different components of the thoracic cage. First we will talk about ribs. Now as you know, the ribs are basically a thin arch of bone. I'm sure you have seen ribs, and you have seen ribs when you were looking at the skeleton, the total articulated skeleton, and you see that they are thin arches of bone. Okay, so if you look at the ribs, all of the ribs that humans have, you can divide them into several different types. Okay, so the first type is what we call the true rib. The true rib or the vertebrosternal ribs. The true ribs or the vertebrosternal ribs, we call them true ribs because they are connected to the sternum. That's why we call them vertebrosternal. That means these true ribs they articulate with the vertebral column behind and the sternum in front. Okay, so these are called the true ribs, and the first 7 ribs, that is the first to the 7th ribs, are true ribs, and the rest we call them false ribs. And that is, the false ribs are divided into 2 groups: the vertebrochondral ribs. The vertebrochondral ribs, those are the ribs that their costal cartilages are attached to the costal cartilages of the rib which is above. They are not directly articulating with the sternum. So they articulate with the vertebrae and with costal cartilages. That is why they are called false ribs, and they are called vertebrochondral because they articulate only with the vertebrae and the costal cartilages. So these are the 8th and the 8th to the 10th ribs, that is 8th, 9th and 10th rib. Then we come to the floating ribs or the vertebral ribs. Floating or vertebral ribs which are not connected to anything in anteriorly but are connected to the vertebral column or the vertebrae posteriorly. So they are free at their anterior extremities and they are connected to the vertebrae posteriorly. And those are the 2 ribs, 11th and 12th. Okay, so the true ribs are the first to the 7th. Then false ribs are from 8th to 12th, and from those the 11th and the 12th are called the floating ribs. so when you come to talk about ribs, we generally talk about what is called a typical rib. So typical rib is actually most of the ribs. Most of the ribs have this typical appearance. Now a typical rib will have a head, a neck, a tubercle and a shaft. Okay, a head, neck, tubercle and a shaft, and on the shaft will kind of curve at a certain point, which we call the angle of the rib. So this is what a typical rib will look like. When you come for the practical later, you will be able to see these ribs and study them close up. Okay, so if you look at it closely, the rib, if you look at the posterior end of the rib, you can see the head nicely here, and the head has two articular facets. Okay, there are two articular facets to the head of the rib. Alright, and the head has two articular facets, and these two articular facets are there to articulate with the body of the thoracic vertebrae. So as I told you, all of the ribs are attached to the thoracic vertebrae. So the head of the rib is attached to the thoracic vertebrae on the bodies. Okay, so you have the inferior and the superior facets on the head for this articulation. Then you have a slightly narrow part which is called the neck, and then you see the tubercle here. Now the tubercle also has an articular facet which is there for the articulation with the transverse process of the thoracic vertebra. Okay, so the tubercle has one articular facet for the articulation with the transverse process of the vertebra. So here you can see a rib which has been placed on a flat surface, right? So when you place it like this, you see that the shaft of the rib is flattened from side to side. So it is antero-posteriorly flattened, so that you have an anterior surface and a posterior surface, and because then the superior and the inferior edges are thin, so we call them superior and inferior borders. Okay, so then again, if you look at the shaft carefully, the inferior margin of the shaft or the inferior border of the shaft, you will see a very small slight groove, right? So this groove is called the costal groove, and this is important because the neurovascular bundle, that is the intercostal vessels and nerve, travel in this tiny groove. So that is important. So when you look at a rib, you should look at the costal groove on the inferior border. Now here you see all the ribs in the thoracic cage. So that is the first rib and that is the 12th rib. So all the ribs are placed in this order, and you can see that all the ribs are nicely curved, and here you can see the curvature is really high on the first rib. The curvature is most curved, or the curvature is greatest at the first rib, and then the ribs tend to open out. They open out as they go downwards and they become bigger and bigger, so that you get this particular shape of the thoracic cage. And as you come down again, the ribs become slightly smaller, but the curvature remains kind of open. So if you take the 12th rib and the first rib, you see that the first rib is very highly curved, and the 12th rib is almost just like almost straight. Okay, so we talked about typical ribs, then we talk about the atypical ribs. So atypical ribs are the ribs that are different from the typical appearance. They have features which are different to the typical appearance. So what are these atypical ribs? You have the first rib, the second rib, the 10th rib, the 11th rib and the 12th rib. So these ribs are atypical. Okay, so first rib is actually very important. You will be studying about the first rib again when you do neck, head and neck section, because that is again the place where the thorax and the head and neck meet like. which we call the thoracic inlet, which is bounded by the first rib. So if you look at the first rib, it is quite different from the other ribs. The first thing that you will notice is that it is flattened inferior superiorly, above downwards. It is flattened above downwards, right? So the superior surface and the inferior surface are flat, not the anterior and the posterior surfaces. So you have an anterior margin, a posterior margin, or an outer margin and an inner margin, and a superior and inferior surface. Okay, right. So then you see that the head is there. It is small and it has a single facet because it's going to articulate with the first thoracic vertebra and only the first thoracic vertebra. Because of that, it has only one articular facet, okay, on its head. The head is small, has a single articular facet for articulation with the body of the first thoracic vertebra. Okay, and then you have a tubercle which is quite prominent, okay, with the tubercle here on this side, and you don't really see an angle, you see a very clear sort of round, nice smooth curve. Okay, so that is the first rib, which we call a atypical rib. It is very obvious that it is atypical and it's different from the other ribs. Okay, so if you look at the first rib more clearly, you can see the surfaces. So here this is the upper or the superior surface. There are several grooves and areas where you can see different structures will be related to the first rib, right? So the first rib superior surface, you have two grooves, right? So you have two grooves here, and the two shallow grooves are there. So the anterior groove, now this is the posterior aspect where it articulates with the thoracic vertebra. This is the anterior aspect, right? So the anterior groove is for the subclavian vein, and the groove behind that is for the subclavian artery and the lowest trunk of the brachial plexus. Okay, I'm sure you remember that from studying upper limb. And then behind that you have again a rough area, because for muscle attachments you get rough areas, for vessels you get smooth areas. Okay, and a rough area for the attachments of the scalenus medius muscle, which is a neck muscle, and you will be studying it. I'm sure you saw it when you were discussing about the brachial plexus, right? So between those two you get what is called the, between the two grooves, the subclavian grooves, you will see the small tubercle here, which is called the scalene tubercle, which is there for the attachment of the scalenus anterior. Okay, so this is for scalenus medius, this is for scalenus anterior, and these are for the subclavian artery and vein. Alright, and also there is a small area here for the serratus anterior as well. Okay, then the second rib is also slightly different from the other rib. It's also called an atypical rib. The curvature is a little bit similar to the first rib, and you get the the curvature is similar, and there is a very small costal groove and a slight angle only, right? So when you look at the second rib, it looks a bit like the first rib because the curvature is the same, and also it is some parts of it is posteriorly flattened, okay, and some parts slightly flattened superior inferiorly. Okay, so that is the second rib. And then when you come to the 10th rib, the 10th rib has all the other parts, however it has only one articular facet on its head, right? So on the head you get only a single articular facet in the 10th rib. Then when you consider the 11th and the 12th rib, the last two ribs, again as I said, they just look, they are quite small, right? And they both have single articular facets on their heads, right? And the 11th one does not really have a neck or a tubercle, and there's a slight angle with a shallow costal groove. That is the 11th one. Then the 12th one is mostly like a small piece of bone. It does not have a neck or a tubercle. There is no angle, or you cannot see a costal groove. Okay, so the 12th rib is shorter than the 11th and maybe even shorter than the first rib, right? So sometimes the first rib is the smallest one, otherwise it is the 12th rib which will be the smallest. Alright, so it's just a piece of bone. However, remember 12th rib is very important when it comes to different attachments. The diaphragm and also different muscles of the posterior abdominal wall is attached to the 12th rib, and it is a very important landmark, though it is a small piece of bone. Okay, so those are the ribs that we talked about. Now let us talk about the sternum. Now if you look at the sternum, it looks like a dagger, right? A knife. It looks like a knife. Okay, so this is called the sternum, and it has three parts: the manubrium, which is the superiormost part, then the body of the sternum, and then what you call the xiphoid process. Okay, so these three bones are connected to each other at these angles. Okay, so this is the manubrium, this is the body of the sternum, and this is the xiphoid process. Okay, so here you see the lateral view of the sternum, the side of the sternum where it articulates with the ribs. Okay, so here you can see in the manubrium you have what we call the clavicular notch, where the clavicle comes and articulates. You learned this in upper limb, and then below that you get the depression or the surface for the articulation of the first rib. Okay, costal notch, this is called a costal notch. So the costal notch for the articulation of the first rib, and then you get the demifacets. There are two demifacets. One demifacet is on the demifacet means demi means half, right? So demifacet on the manubrium and another demifacet on the body of the sternum. So together they will form the articular surface for the second rib, right? So the manubrium and the body of the sternum. So here the second rib will articulate here. Then after that, the body of the sternum has lots of small articular facets for the rest of the ribs. From this is the third one, fourth, fifth, sixth, and finally the seventh, right? So costal notches from the second to the seventh costal cartilage is there on the lateral side of the sternum. Okay, so we've discussed about the sternum as well as the ribs. So now we will go and discuss about the thoracic vertebrae. Okay, so I don't think you have learnt about vertebrae yet. So because of that, we'll give let you know the general features of any vertebrae is that it has a vertebral body, right? So from that vertebral body, you get what are called pedicles, right? So two pedicles come and then they fan out to form what is called the lamina, right? So the two pedicles are then there, and then there are the lamina, and the two lamina come together posteriorly and form the vertebral spine. Okay, this is the spinous process or the vertebral spine, the spinous process. Okay, so where the pedicles and the laminae meet, you get transverse projections, which we call the transverse processes. Sorry, transverse processes, right? And then again at these junctions you will be able to see what are called articular facets, the superior and the inferior. So these are these are the articular facets, the superior articular facet and the inferior articular facet. These are there for articulation with the rib which is above and the vertebra which is above and the vertebra which is below, right? And this is the spinal canal where the spinal cord will go through, right? We can call this the vertebral canal or the spinal canal, right? So you have four articular processes, the two superior articular processes and two inferior articular processes. Okay, right? So if you look at the thoracic spine, as I said, which forms the posterior border of the thoracic cage, it starts from the first thoracic vertebra and ends at the 12th thoracic vertebra. And this is a primary curve. It is C-shaped and it is a primary curve, because in a child you will get the primary curve and the thoracic spine does not curve further, and towards adulthood it will remain the same C shape. Okay, so if you take thoracic vertebra and look at it, you see that it is of intermediate size. Now if you look at all the different vertebrae, you see that the cervical vertebrae are very small and the lumbar vertebrae are quite large. So the thoracic vertebrae are actually intermediate in size. Now remember that this is actually a comparison between vertebrae and not a real typical feature of the thoracic vertebra. Okay, so again this the size of the vertebrae increases as you go downwards, because the weight bearing aspect of it increases. As the vertebral column goes down, the bodies of the vertebrae become larger and larger. So this same thing is seen in the thoracic vertebrae as well. Okay, so what are the features which are common to all thoracic vertebrae? That is the presence of facets or demifacets or facets on the sides of the body of the vertebra for articulation with the heads of the ribs, right? So one feature which none of the other vertebrae have is that the thoracic vertebrae articulate with ribs, and this articulation is at the body of the vertebrae. Okay, so you can see demifacets on either side of the body, superiorly and inferiorly, for the articulation with the head of the ribs. Now we saw when we talked about the rib that the head of the rib has two facets, the superior one and the inferior one. Okay, so they will articulate with this demifacet of the vertebrae. Also you will see that the transverse processes also have articular surfaces. Okay, so we again call them facet. So there's a facet on the transverse process for articulation of the tubercle of the rib. Okay, so when you come to the dissection lab, you can use a thoracic vertebra and a rib and articulate it and learn to articulate this and look at the different joints. Okay, so as I said initially, the 11th and the 12th vertebrae do not have facets on the transverse processes, because the 11th and the 12th ribs do not have tubercles. Okay, so again if you look at the body of the vertebrae, you see that there are two facets on either side. Okay, so we say that the body of the thoracic vertebra is heart shaped. Okay, so this is a general thing that we say, it is a heart shaped body. Okay, and it has demifacets on the superior and the inferior surface. Okay, if you look at the spinous process of the thoracic vertebrae, you see that it is quite long and triangular and ends with a tubercle. Okay, so the extremity or the end of the thoracic vertebral spine ends with a sort of a knob here. Okay, so we call it a tubercle. So the end of this is tuberculated. Okay, ends in a tuberculated extremity. Okay, and then it is directed obliquely downwards. Okay, so these are features that you will see if you look at the different parts of the vertebral column. You see that the spinous processes are differently orientated. So in the thoracic spine, you see that the spinous process is directed downwards. Okay, so then next we will look at the articular processes. As I said, you get superior articular processes and inferior articular processes. So this is the superior one, this is the inferior one. Alright, so the superior articular facet, these are nicely rounded and smooth. When you study, you can look at a bone and see. If you have an atlas, a bone atlas, you can look at that as well and study that. Okay, so the superior articular processes, the face of these, the facets are directed backwards, okay, posteriorly and also outwards. Okay, it is turned outwards. So it is backwards and turned outwards. And the inferior articular process is absolutely opposite, that is, it is directed forwards or directed anteriorly and turned inwards. Okay, so it is looking inwards and anteriorly. Okay, so the inferior articular process is looking inwards and anteriorly. The superior articular process is looking posteriorly and outwards. Okay, so this is because the superior articular facet will articulate with the inferior articular facet of the vertebra which is above, and the inferior articular process will articulate with the superior articular process of the vertebra which is below. Okay, now let's look at the transverse processes. They go transversely, that's why they are called transverse processes, and on these they are quite thick, strong, and quite long in thoracic vertebrae, and they are directed slightly backwards and outwards. Okay, and they have a clubbed extremity. And they have a nice smooth articular facet for the tubercle of the rib. Okay, so these are the features of a typical thoracic vertebra. Okay, so typical thoracic vertebra will have a heart-shaped body with two demifacets superiorly and inferiorly for the heads of the ribs. They will have superior articular processes directed backwards and looking outwards, inferior articular processes directed inwards and looking anteriorly, and articular facets on the transverse processes downwards, spinous process which goes downwards and ends in tubercular pattern, right? There is a tubercle at the end. So these are the features of a typical thoracic vertebra. Okay, so since we talk about typical thoracic vertebrae, that means there are atypical ones, right? So there's the first rib, the 9th, the 10th, the 11th, and the 12th. Sorry, vertebrae. Okay, sorry. So we have the first, 9th, 10th, 11th, and 12th vertebrae are atypical. Okay, so these are the first, 9th, 10th, 11th, and 12th. All right. Okay, so if you look at the first thoracic vertebrae, why is it atypical? You can see that it has only a single demifacet, not a demifacet, a full facet on the superior edge of the body. Okay, so if you look at thoracic vertebra and you want to figure out whether it's the first thoracic vertebra, you can see that superiorly it has a single facet and inferiorly it has a demifacet. Okay, so that is the atypical or the difference in the first thoracic vertebra. Okay, then the 9th thoracic vertebra, it does not have a demifacet inferiorly. Okay, so the inferior demifacet is missing. There's only a superior demifacet. So that this is the only vertebra that looks like that. So that is the 9th one. Then the 10th one has a full articular facet because the 9th one doesn't have a demifacet. The 10th one has a single full articular facet superiorly. That's all. Okay. Then the 11th one also has a single articular facet superiorly. 11th thoracic vertebra has a single articular facet superiorly. So when you come to the 12th thoracic vertebra, you can see again it does not have a facet on its transverse process just like the 11th one, and also you can see that there's a single articular facet on the body. And then if you look at the inferior articular process, you can see that it is turned outwards. Okay, it's not turned anteriorly, it is turned outwards. This is because the 12th thoracic vertebra goes and articulates with the first lumbar vertebra, the L1 or the first lumbar vertebra, and because of that the articular process or the articular surface is different to those of the rest of the thoracic vertebrae. Okay, so that brings us to the end of the osteology part of this. Now we'll talk about the surface anatomy. Okay, so this picture shows you the anterior thorax, a photograph of the anterior thorax. Now here you can see the area where it's very easy to palpate is the it's the suprasternal notch here, right? So you go on your own self, you can do this. You go to the root of the neck and you can feel this notch here, which we call the suprasternal notch. Okay, so you palpate the clavicle when you did upper limb, right? So that is the clavicle, and you can feel it. The whole of the clavicle is subcutaneous, so you can palpate that. And then from the suprasternal notch, if you go downwards, if you move downwards in the midline, you will come to a small area where it's easy to palpate, which we call the angle of Louis. Okay, so this is the sternal angle or the angle of Louis, and you can feel the angle. And right next to that angle, you get the second costal cartilage, and the second rib arises from that, continues from that. All right, and then if you go down again along the midline, you will come to another small area where that will be the siphisternal joint, right? So slight elevation will be felt, and then you can feel the edge of all the ribs and the cartilages which form the costal margin, right? So the edges of the 7th, 8th, 9th, 10th ribs, right, anteriorly with their costal cartilages will form the anterior costal margin, and posteriorly they will extend, and the 11th and the 12th ribs will be joining posteriorly. Okay, so all these bony points are easily surface marked and felt on your own self, or in a volunteer, some relative, you can ask someone to help you out with this. Now the surface anatomy handout will also be uploaded, so you can take that and do the surface anatomy on a volunteer. Okay, so this is a picture of the posterior thorax. If you go to the midline at the root of the neck, the first palpable spinous process is actually that of the 7th cervical vertebra. Okay, the 7th cervical vertebra, and we call it the vertebra prominence. Okay, so that is what you can feel here, and then we go downward slowly. You can feel all the other spinous processes of all the other thoracic vertebrae downwards, right? In a thin subject, this will be quite easy to do. All right, and then of course you can see the scapula, you can see the margins of the scapula. You might be able to see the spine. I mean, not very easy because of the muscle bulk, but you can definitely see the inferior angle, right, and the vertebral or the medial border, and some of these. If it's a very thin subject, you can actually quite easily see the scapula. Okay, so then when you're trying to surface mark the different organs in the thorax, you need to we generally talk about these lines of orientation, right? So this is the midline that goes right in the middle of the sternum, right in the middle. So starting from the trachea downwards, it goes straight, that is the midline, and dissecting the umbilicus. Okay, so that is what you call the midline, and then you have what we call the mid-clavicular line. Now you have the clavicle, right? So if you can feel the two ends of the clavicle, the sternal end and the scapular end, right? You feel the two ends, and right at the middle of the clavicle, you draw a line downwards that is called the mid-clavicular line. And in males, it goes across the nipple at the level of the 4th intercostal space. then there are three other lines which we call the anterior axillary line, the posterior axillary line, and the mid axillary line. So when you lift your arms above the head, you have the anterior axillary fold which forms the anterior wall of the axilla, and that downwards is called the anterior axillary line. And then the posterior wall of the axilla, that downwards is called the posterior axillary line, and in between these two lines you get the mid axillary line. Okay, so this is a diagram to help you remember with the clavicle, the sternum, and the ribs. Okay, so you can feel most of the ribs, the costal margins, and all that in a thin subject, and you can see the clavicles, and you can mark out your midline and the mid clavicular line, imaginary lines on the anterior chest wall. Okay, so now that we know about these projections, we will talk about the surface marking of the different organs of the thoracic cavity. Now the handout that has been uploaded will give you the same things. I have listed out the same things here, so you can try this out on a volunteer, or even yourself you can do this. Okay, so initially when we surface mark the pleura, we start we have to remember that the pleura extends above the clavicle. Okay, the pleura extends above the clavicle, and the apex of the pleura is surface marked 2.5 centimeters above the medial third of the clavicle. Okay, medial third of the clavicle, and it passes behind the sternoclavicular joint, right? It passes behind the sternoclavicular joint to reach the mid-sternal line at the level of the second rib. Okay, so here it starts here, 2.5 centimeters above the medial third of the clavicle, and then goes down, going behind the sternoclavicular joint, and then going towards the midline, and reaching the midline at the level of the second rib or the second costal cartilage. So the other side also it will come and meet up here, and the two lines will be parallel and going downwards. So then this line passes vertically down along the mid-sternal line. Okay, and on the right side it will continue down towards the sixth costal cartilage. It will continue down towards the sixth costal cartilage in the midline. On the left side, because the heart is there, at the fourth costal cartilage, it will curve out laterally to allow space for the heart. Okay, and then again from the sixth costal cartilage downwards, it is the same. From these points, the two lines will move laterally and downwards. Okay, and it will meet the mid clavicular line. Okay, mid clavicular line at the 8th rib. Okay, mid clavicular line at the 8th rib, and the mid axillary line at the 10th rib, mid axillary line at the 10th rib. Okay, and at the 12th rib, the lateral board of the erector spinae, and from there they run horizontally. Okay, that is the posterior aspect, horizontally to the spinous process of the 12th thoracic vertebra. Okay, is that understood? Okay, right. So that is because you have the left and the right pleura slightly different, but most of it is the same, except for this area where there has to be some space for the heart. Okay, right. So then we move on to the surface marking of the lungs. All right, so at the apex, the lung follows the same surface marking as the pleura. Okay, follows the same line as the pleura from the apex downwards. Okay, so at the mid-sternal border, it will go parallel, and then again on the left side it will form this curvature similar to the pleura. There is more space where the heart will be. Okay, there will be more space. And then when it comes to the posterior edge, the lung is smaller than the pleura. That is why you get what we call the costodiaphragmatic recesses. The two pleural membranes come into contact with each other and there is no lung substance there. Okay, so that area is left free of lung, the blue marked area marked blue on this diagram. Okay, so because of that, the posterior edge of the lung, you get the surface marking slightly higher than the pleura. Okay, right, so the lower border of the lung, it overlaps the sixth rib at the mid-clavicular line. Okay, so at the mid-clavicular line, it is the sixth rib. It is about 2 ribs above the pleura. Okay, mid-clavicular line, and then the 8th rib at the mid-axillary line, and then it continues backwards at the 10th rib, the lateral border of the erector spine. Okay, crosses the 10th rib at the lateral border of the erector spine. So basically it is slightly higher than the pleura, so there's a space left. Okay, and then a line joining the spine of the 3rd thoracic vertebra to the 6th rib in the mid-clavicular line indicates the position of the oblique fissure, right? So the oblique fissure is a fissure in the lung, right? When you study the lung, you will see the oblique fissure, so on each side, and this is approximately the line of the 5th rib. Okay, 5th rib or the vertebral border of the scapula, the 5th rib or the vertebral border of the scapula, when you raise the arm fully, that means abduct the arm above the head. Okay, so that is the surface marking of the oblique fissure. Okay, then on the right, a line passing through the 4th costal cartilage to meet the oblique fissure at the mid-axillary line indicates the horizontal fissure, right? So the horizontal fissure is only there on the right side, oblique fissure is there on both sides of the lung. Okay, as you know, the right lung has 3 lobes and the left lung has only 2 lobes. Okay, now next we will talk about the surface marking of the heart. Now remember, all these surface markings are very important because when you are doing any kind of procedure to the thorax, you have to be very careful not to damage the pleura or the lung, and because of that you need to know where the pleura and the lung is, right? So also remember, the pleura extends into the what we actually call the abdomen, right? So even in upper abdominal procedures, you have to think of the pleura, not to injure the pleura. Okay, so when you are going to surface mark the heart, okay, sorry, remember that about 1/3 of the heart, most of the heart, 1/3 of the heart lies on the right side of the midline. Okay, so that is the midline, and on the right side you get about 1/3 of the heart, and rest of the heart lies on the left side. Okay, so you can do the following on a volunteer or basically on yourself as well. So first of all, you need to remember the most important thing is to remember how to surface mark the apex of the heart. Okay, so the apex of the heart is surface marked in the 5th intercostal space. 5th intercostal space, about 9 centimeters or a hand's breadth from the midline. Okay, and that comes to the the mid-clavicular line. Okay, so 9 centimeters left of the midline in the 5th intercostal space. That is the surface marking of the apex of the heart. Alright, okay, then we'll talk about the borders of the heart and how we do that. If you take the right border of the heart, it extends from the lower border of the right 3rd costal cartilage to the lower border of the right 6th costal cartilage. Okay, so that is just lateral, about a few centimeters lateral to the midline, or just a few centimeters lateral to the edge of the sternum, right, the lateral edge of the sternum, and this is slightly convex to the right, and from there you get the inferior border which passes from the right costal cartilage right sixth costal cartilage towards the apex on the left side at the fifth intercostal space. Okay, and then from there, from the apex, the left border extends upwards, okay, upwards, curving upwards to the second costal cartilage, about 2 centimeters away from the lateral sternal margin. Okay, so remember that carefully. The second costal cartilage here, the third costal cartilage here, the sixth costal cartilage here, and the fifth intercostal space here. Okay, so those 4 points, when you join them up, you get the surface marking of the heart. All right. Okay, so remember this very carefully, because if you're trying to introduce a needle somewhere in the thorax, you don't want to go into the heart, right? So that might be deadly. I'm sure you realize that. Okay, so then another thing is that we have the cardiac valves, right? So this picture shows you where you can surface mark the cardiac valves. Most importantly, you need to remember the auscultation areas. That is where you listen to the sound of the different valves, right? So when the blood goes through each of these valves, they create a specific sound, and the normal sound is there, and you have to be very you have to listen to the normal sound, so that you know if there is any abnormal sound, which can be due to a defect in any of these valves, right? So if you're going to listen to the aortic valve, generally the aortic valve is surface marked here behind the sternum, like a line down here, right? So the aortic valve is here, but the sound of the aortic valve is projected like this towards the right side, the second intercostal space, right? So just lateral to the sternal border, second intercostal space is where you would be listening to the sounds of the aortic valve, right? So similarly, on the other side, the opposite side, the left side, you will be listening to the pulmonary valve sounds, auscultating for the pulmonary valve sounds. So this is the surface marking of the pulmonary valve. And then you have the mitral valve next, and that is projected towards the apex of the heart. And then you have the tricuspid, which is projected again towards the right side, lower sternum, right? So these are important to remember. You will again do this as a practical in physiology, and you need to learn and understand the how the valves, the sounds of the different valves.